Welcome to Disrupting Death. Today's episode contains conversations about ancestral, epigenetic, and somatic trauma. Dear listeners, we invite you to please take care of yourselves as you lean in to listen.
Hi, Carrie Lynn. It's time for another episode.
I was hoping you'd say that. Who do we get the opportunity to speak with today?
So I think this is super cool. Listeners, you know I really like it when people reach out to us and say they've got things they want to contribute to our conversation around disrupting death, around conversations about medical assistance in dying. And today we have the privilege of speaking with Dr. Chirstine Gibson, who is a family doc from Calgary, Alberta, with a really strong background when you and I were doing that deep dig in social justice work, in medical education, and global health. And she is also a MAiD provider who has recently published a book called The Modern Trauma Toolkit. And I don't know about you, Carolyn, but I want to hear more about this idea of really connecting what we call in social work, which I suspect is also common language for Dr. Gibson, a trauma-informed practice around MAiD.
Absolutely. And having had the ability to sit down with her book, and as a person who doesn't necessarily dwell in healthcare education specifically, so much there that I'm curious to hear about. Even the title itself, why modern? If trauma is how we respond to something, what are the tools and skills that we need to really navigate those spaces?
And I also anticipate she's going to be pretty funky to talk to as well, because she's got a fairly strong social media presence on TikTok as Trauma Doc. So why don't we talk about disrupting death with Dr. Gibson? Chirstine, I'm so glad you were able to join us today. I wanted to start off just by saying thank you so much for reaching out to us, suggesting yourself as a guest and wanting to have a conversation, because we really appreciate that. It helps us to expand on who we have the privilege speaking with. And so why did you reach out to us, Chirstine? What is it that you're hoping we're going to talk about today?
Correct me if I'm wrong, but the name of your podcast is Disrupting Death, right?
You betcha.
I just loved that. I'm learning a lot about death. What's interesting is a physician for over 20 years. I did a lot of inpatient medicine for 16, 17 years, and I saw a lot of death in a hospital setting. Sadly, it's where most people don't want to die, and it's where most people die. And it wasn't really what I had imagined for myself or my loved ones, the way that it happens. So many times it happens because there's not been a sufficient conversation about what their wishes are, and we end up running a code, which is really hard to watch when you're not certain that's what the person would want as their final moments on earth. So many times they're alone. And I think because of the current discourse, especially in Canada, but then also the perception of Canada overseas, my experience with MAiD over the last 8 years, because I have been a provider since the very week it was legal, is really different than what's happening in the news. And my own experience with it, I consulted a death doula and said, what does a good death look like? There's this saying that Rachel Naomi Remen says about what does it look like to heal when cure isn't possible? And that's really what's on my mind about when you know that your death is planned, what is the most generative way to approach it? Like, how can it be beautiful and healing? And that's a question that I ask a lot. And I think the words disrupting death just makes me think about my journey over the last while.
Thank you for saying that. It was a title that we wrestled a little bit with, and we've been called out a bit on the title, which I love, because I think we should, of course, be thinking critically about it. But for me, I feel in some ways our podcast is encouraging conversations that don't normally happen in different spaces. And I love that quote from Naomi Remen as well. And it linked to me as you were talking, I was thinking about Dr. Catherine Mannix out of the UK, who is also a palliative care physician, who talks about that we don't have conversations enough about ordinary dying. And from my perspective, I think we've been called to action in a different way in Canada with the legalization of medical assistance in dying. And that we need to make sure that people understand the opportunities and options available to them so that they can have that choice at the end of life. Can I ask a follow-up, Chirstine? What motivated you to start being a MAiD provider at the onset? And back in 2016, there were a few people who were saying, nope, not for me. What motivated you?
It was interesting when we knew that MAiD was going to be legal. My hospital put out a survey for all of the doctors with admitting privileges and asked if any of us were willing to go ahead with it. And it didn't really cross my mind that it was something that people would say no to. I thought this is a medical procedure that people are legally entitled to. And if we have the capacity to do it, there would be very few of us that would say no. And I was wrong. Out of the hundreds of physicians with admitting privileges to my hospital, I was the only one who said yes. That first year was really hard on me psychologically because I was wondering why I was the only one. And some of the conscientious objectors, both nurses and physicians and administration, made my life really difficult. So I never questioned whether I was doing something that was morally and legally right, because to me it was clear that it was. The deaths that I oversaw that were made provisions in hospital were such a better death than anything else I had seen there. They had family around them. It was their choice. They decided when their suffering was enough. And as a physician, so often we just tell the patient, especially in a hospital environment, this is what I'm going to do to you today. And there's so little negotiation. There's so little true consent that happens. This is the one time where I felt like, wow, patients have so much agency here. So even though it was admittedly very difficult for me, professionally and personally, to be the only one, I was really glad that I did it.
Can I ask you specifically, what have been some of the rewards of engaging in that way, where people have true choice at the end of their life, making sure that they have that capacity? Because I'm just going to remind our listeners that is part of the essential piece with MAiD, that people give that consent before the medication is administered, before the provider does anything, and people still can say no right at the time of the administration, before it's administrated, of course, but at the time.
I really believe that the people that I have administered MAiD to want it desperately. There is so much suffering towards end of life. Most of what we see is end of life suffering. As a physician, I think it's almost arrogant to believe that we can alleviate all forms of suffering, and palliative care does an incredible job. They definitely can do a lot when it comes to pain and other kinds of symptoms, but it doesn't work for everybody. So first, we need excellent access to palliative care. Luckily, where I am, it seems to be really good. I've yet to encounter a person who was looking for palliative care and didn't access it. But it's not always the route to end suffering for some people. And that suffering can be physical, that suffering can be psychological, and that suffering can be existential and just a fear of the end and uncertainty. But that suffering can be extreme. And so nobody goes into this decision lightly. Many people will be assessed for MAiD and have approval and know that they're eligible and they could access it at any time, and they choose not to because just knowing that it's an out that they could take is such a way to alleviate suffering. So firstly, I think it's really important to know that is a real possibility for people. And I think just putting it on your menu and knowing that if it's intolerable, you have this possibility is such a healing thing for people. And I appreciate that so many people want to know that they could use it and they are eligible, and then they choose not to if it's not something they decide that they want. Or really it happens that they'll schedule the MAiD event and then they say, you know what, actually, I can handle this. I'm going to cancel the event. So I think that sense of control over your death is a really healing prospect for many. And for the people who don't choose to access it, that is also their choice. So for all of the people who are fighting against MAiD being legal, I'm saddened because it would make it illegal for people who really want it, whereas the people who never wanted it would just simply never access it to begin with. So you're taking that choice away from people who desperately wanted it. And that's what brings me so much comfort, is knowing that every single time I'm alleviating suffering in some way. And I have seen both sides of that coin. I've seen so many truly awful deaths in a hospital scenario. And then I've attended some incredibly beautiful deaths. I was late for this recording this morning, and as I was administering medicine, they were playing this Bocelli, like, just absolutely stunningly beautiful song, and tears are running down everyone's faces in the room. It is such a beautiful death when you have total control over it. So yeah, it's an absolute privilege for me to be involved.
Thank you. I think that this is a good segue into the book that you wrote and another facet of what you were hoping that we talk about today, and the term trauma. But I think what I'd like to start with, because having read the book, I really appreciated being taken through a deconstruction of the book's title, Modern Trauma Toolkit. I'm wondering if you would do that now, Chirstine, for our listeners, please.
I'd love to do that, and probably just add a corollary around what we're talking about. So I wrote the book, The Modern Trauma Toolkit, because I transitioned from doing pure family medicine in the community while running wellness programs, actually, for a while at a community health center. And then I learned a couple of trauma therapy techniques that worked against PTSD. And once I had done that with my family practice patients who had almost universally undergone a lot of childhood trauma, I started to notice that their physical health improved. And so as I studied more and more about complex trauma, I understood that this was underlying a lot of behaviors and illnesses and mental health issues that we were seeing in community. So I wrote the Modern Trauma Toolkit as a primer. It's to help people understand what happens as a child in terms of not just significant events like experiencing or witnessing violence. Of course, that's trauma. But a lot of people don't recognize that attachment wounds, like feeling like your parents just don't care, or for any reason that you feel like the world is dangerous. So poverty or racism are really traumatic, and that affects you and the way that you see the world as you age. This is something that I don't think a lot of people understand, and there's been this backlash about the use of the word trauma. So I use the word modern because there's so many different ways that we're aware of events around the world. And so witnessing trauma can have a traumatic impact in the brain, because trauma isn't the event. Trauma is how your brain responds to the event. And as somebody who's on TikTok, I'm TikTok trauma doc. I see that witnessing as being incredibly painful for young people. They're witnessing inequity, they're witnessing war in a way that I never experienced in my 20s. Even the concept of MAiD and the way that the public discourse has been happening is incredibly traumatic, because what people are saying about MAiD in Canada is that we are coercing people with disabilities into MAiD. I've personally never seen that. And it's so heartbreaking for me to think of the medical trauma that causes for people to truly believe that a doctor would want you to die. Like that. That makes me really sad.
Me too. Me too. Yeah, Chirstine, thank you for being so vulnerable around that, because I think that's a big one. This idea of an entire profession whose job is to cause no harm. That's part of the oath, as you well know. And that we are moving this idea that assisted death is harmful. But I appreciate your discussion around the trauma piece, recognizing the suffering. And as you were talking about the younger generation, and I have the privilege of being an educator for the future healthcare providers of tomorrow in my work, and many of them haven't had exposure to, again, the Dr. Mannix term, ordinary dying. They're not seeing that in the same way. Or if they have been a witness or part of someone's dying, it has been that traumatic suffering that you were talking before. And so I think what you're talking about in terms of the modern toolkit piece pays attention to providing some support and education and space so people can be prepared to see dying and death as part of life.
Yeah, this is the cycle of life, and death is certainly a part of it. It's one thing that we will all have happen to us. The Western world has such a fear around death. I think it's part of what drives many medical decisions. We will give dialysis to somebody who has dementia. We will tube feed somebody who's unconscious. We will do these things. And I think part of it is physicians aren't taught well how to recognize futility and to recognize when the body is shutting down. And we rail against it as if it's something that's unnatural when it is the most natural thing that happens to all of us. And I truly believe that a person with a disability does not choose MAiD lightly. Firstly, it is their choice. And secondly, the amount of suffering that it takes to believe that death is preferable is tremendous. And I think it's important that they have that choice. And that doesn't preclude me as an actual activist. I'm not an advocate, I'm an activist against equity. And I have been for my entire career. I literally created a residency in health equity. So I trained students to work in the inner city with immigrants and refugees. I myself work at the refugee clinic and in adult addictions. I've always worked in communities that were placed at risk through systemic violence. And so I am the first person to say people with disabilities deserve better. They deserve better disability income. They deserve better care. And that they do undergo a lot of medical trauma. Medicine is quantifiably racist and ableist and fattist and homophobic and transphobic. And so many people, folks with neurodivergencies, they suffer at the hands of the healthcare system. And I don't want to discount that. I really do believe that's true. And I believe that's traumatic. So when I talk about modern trauma, that's a part of it too. I do not think that every encounter with medicine has been easy for people. It hasn't been for me. I was recently gaslit by a physician. But I really do believe that the people who are providing MAiD in Canada, by far and large, are doing it with conscientiousness and compassion and clarity in mind. I don't think we are intending to coerce anybody. And it really breaks my heart. That's the dominant discourse right now in Canada. And there was a documentary in the UK when I was there on my book tour at a conference. I was confronted by some people for whom that documentary had been really terrifying to hear that perception of what was happening here in Canada around death. And I don't want to discount anybody who's had a different experience. I just want to say what my own is. But I've been involved with MAiD since the week it was legal. And this is not what I see. I see people at the end of life who are suffering tremendously. So in my book, in the Modern Trauma Toolkit, I have a whole chapter on death and grief and loss, because I don't think that we've learned to handle this as a population. Like, this is not a life skill set that we've been given. And I really don't think as a medical profession that we've been taught how to manage it, not just in our patients, because so many of them go through grief and loss, but we do almost daily. And what we learn to do is to stuff it. That's definitely in the apprenticeship model what I learned, because you could encounter a death, a natural death of a patient or a code of a patient, and then you get paid to see that person for 20 minutes, and then you have to go on to the next person. We don't have rituals and ceremonies and processes that we should be using to help ourselves manage that. And I've had to develop this over the years. Now that I'm more aware of the trauma and the suffering that I hold in my body, I've had to learn how to process that myself. As a part of my personal learning journey, I've learned an incredible toolkit that I can now share with not just my patients, but the general public, whether it's through TikTok or speaking or this book. I really think these are skills that we should be learning in school, and we should be learning just as humans. How do we manage the trauma of grief and loss and suffering?
I'm an educator, and I've been a long proponent of dying, death, and loss education at the elementary school level, perhaps even earlier. So I thank you for that. I want to go back to a term you used a few minutes ago, menu, because that's a term that you use in your book about how you are hoping that people will understand your book as a personalized menu to explore. And so, having said what you said about the trauma, about the suffering, about navigating through spaces where we're going to need to heal because there is no cure, based on what you just said about diversity, of course, I think I understand, but I'd love for you to share why you wanted to offer this sort of smorgasbord of strategies and ideas and messages and mementos for people when they access your book.
As I did research on trauma and toxic stress, there was just so much that I hadn't learned in medical school and that I recognized people didn't know. I trained 25 years ago out in Toronto for medicine, and we didn't learn the term epigenetic. And when I did my undergrad in a lot of genetics, what we now know is completely disrupted. Just to hearken to your title, everything that I thought I knew about genetics. So toxic stress and trauma are inherited. So we pass that down through many generations and we change our DNA and our genetic code based on stresses we encounter. So part of what I wanted to focus in the Modern Trauma Toolkit was, what does ancestral trauma look like? What happens when we actually don't have words? We have this experience that something is anxiety inducing. We worry. We have a feeling like something is threatening or dangerous, and we really can't put words to it. So, this is something I see certainly in the First Nations community. They've inherited this experience of genocide, and not just the modern day version of it, but everything that's happened through centuries. Of course, that inheritance happens in different ways, but it's not something that I understood when I was in medical school. So, part of what I wanted to describe in the Modern Trauma Toolkit is what preverbal trauma looks like. You can experience trauma during birth, but until we're the age of 3, we don't actually have language for the things that we experience. So, we could have an attachment issue with a mom who's suffering from postpartum depression. We could have a physiologically traumatic birth with forceps or surgery, and we could get whisked away into the ICU with tubes all over us and not have a language for this just dreadful sense that the world is dangerous. So, the more that I studied about trauma and toxic stress, the more that I understood that cognitive behavior therapy, which is what I was taught as a medical student and resident, is the gold standard for treatment. It has its uses, absolutely, but it also has its limitations. And so part of what I wanted to introduce to people were evidence-based ways that we can move preverbal trauma through the body, somatic ways, so body-based ways that we can help shift the nervous system response into something more calm and connected. So it's our facial expressions and tone of voice, and that melodic quality to our voice is really calming to the human nervous system. This isn't something I was taught, but if educators and healthcare workers knew this, we could help people show up in what we call the window of tolerance. Dan Siegel, a psychiatrist in the States, talks about what it feels like when we feel like we can cope with what's in front of us. And so many people right now are operating outside of that window. It's not a one size fits all solution. So some of us might be stuck in fight or flight or freeze, and that's going to manifest in different behaviors. Sadly, not enough people are recognizing how that's showing up, but it's showing up in school, in the workplace. It's showing up within the healthcare profession because we are certainly suffering a lot these days. And until we can recognize it in ourselves and others, we certainly don't know how to manage it. So my goal is to try to get the Modern Trauma Toolkit into as many hands as possible so that they'll recognize it in themselves, recognize it in their family members, recognize it in patients and community members and kids that they're teaching, and everybody will have a menu of options to help somebody self-regulate, and that we can do it better for ourselves so that we can also co-regulate, which is what our mirror neurons do. If somebody else is regulating in front of us, then we are more likely to get into that window ourselves.
So as you're talking, Chirstine, I'm thinking about some of the research that Carrie Lynn and I have done speaking with people who've accompanied someone who used MAiD at the end of their lives, and thinking about some of the anticipatory grief, but listening to you, I'm wondering in some ways some of the anticipatory trauma as they're preparing for the day of their person, life to be over, to be ended with MAiD. I can imagine how a healthcare provider might need to prepare themselves to create the least number of ripples as possible in the room and to take care of themselves. Do you have any recommendations for family members or people who are with their person who is accessing MAiD to prepare themselves so that maybe they will experience less trauma? Can I say that? Is that correct?
Yeah, absolutely. It's correct. One of the first things that I did when I realized I was the sole MAiD provider for my hospital is I reached out to a local death doula. Sometimes we talk about having music in the room. Who are their family members? What is the lighting like? What time of day matters to you? And they can find a sense of meaning and connection, which is really what drives all human behavior is meaning and connection. And they can have that right to the last second. Certainly what I experienced this morning was so full of meaning and connection. It was just overwhelming, actually. It was beautiful, humbling. I often will run into people who are experiencing chronic pain that I suspect might be due to trauma, whether it's something that they're aware of or not, that there might be a subconscious experience of trauma. And I will recommend to those people that they seek formal therapy. And I have enough of a toolkit of my own that I can suggest specifically what they might need, whether it's somatic strategies to regulate their nervous system or actually processing a specific traumatic event. I always recommend accelerated resolution therapy in that scenario. But I would want people to learn things like havening and tapping and tools that are in the modern trauma toolkit so that if their nervous system dysfunction is part of what is causing their perception of suffering to be amplified, that they try that first. I don't want people to choose death first. I want them to choose alternatives. And I will always make those suggestions if I think they might be beneficial. One of the other things is you mentioned something about anticipatory grief. And I think many people benefit through writing letters or making a dictation. I write fiction as well as nonfiction, and one of the amazing things that I did was interview my grandma and my dad before they passed away, and so I have family story and family histories on my phone, dictation apps that I've downloaded, and I even have, like, mini cassette recordings because I started it 20 years ago before we had iPhones. We encourage people to make these mementos and create a legacy project, whether that's writing a short story or leaving a little dictation, leaving a playlist of songs behind, something that's meaningful, especially if something that might be culturally significant. And I just want to segue a little bit. I don't know if this is something you've ever touched on, but I think that sense of anticipatory grief is a part of what we're experiencing collectively right now when it comes to the climate emergency. So, one thing that I'm studying is climate psychology. And I really think that a lot of the ways we're manifesting behaviors related to climate change has to do with anticipatory grief. So, we're seeing denial and dissociation from so many people, certainly a lot of government leaders in Alberta, and a lot of the folks coming into the States that are climate change deniers. I actually think this is part of a trauma response. I just gave a TEDx talk in Oshawa a couple of months ago around this subject, but I think some of the ways that we show up when we are dealing with anticipatory grief and loss has very traumatic manifestations. So whether it's denial or dissociation or anger or fear, and the younger generation are in a lot of fear. There was a Lancet study in 2021, 10,000 young people ages 16 to 25, I think, in 10 different countries. So it wasn't a North American bias. These countries in Asia and Africa were also sampled. And of those young people, 75% felt their future was frightening. So there's a lot of anticipatory grief in the youth. It's one of the reasons why I joined TikTok around that time is just to help them with this sense of suffering, this overall sense of threat, and that the world that they're inheriting is dangerous. So I think anticipatory grief is really important when it comes to a single person's death, but I think we also have to think about it from different systems levels, so community and ecosystem. And that's very much on my mind these days. And it's one of the reasons why in the Modern Trauma Toolkit, I don't just talk about the individual ways we can solve problems, but also the systemic and community ways that we need to, because we need to do all of it right now.
Thank you for that. That was certainly something that resonated with me too. And this idea that you propose about the community as expert, but also the community as, I would hope, healing and healed experts. I deal with children and youth on a daily basis who do almost give off a palpable sense of futility about, I don't know if this will be around when I'm your age, I'm not sure, etc. So, very interesting to think about. And I know you're reluctant to use the term empower in your book, and you give very valid reasons why. But the children seem to understand that their power has been taken away from them, that they have been kept from the lives they ultimately would like to live. Certainly in my Western experience. Christine, you explore storytelling and the use of storytelling in your book. That's something that Kathy and I work with regularly. People navigating grief, loss, experience, trauma is understandable in that scenario through digital storytelling. What's the role of storytelling in healing from your perspective?
I'm so glad you're asking it in that way because one of the things that I haven't brought up yet that I think is just really crucial is even though there is ancestral trauma and this epigenetic inheritance that we can inherit the trauma through our lineage, we also inherit ancestral, and I'm going to use the word resilience because it's really the only way that anyone's described it yet. Resilience to me is coming back to a baseline, and I think of post traumatic growth as being an even greater leap towards what's possible. But we so often forget the traditions of our ancestors. So, one of the things that I love to explore is just what are the traditional healing methods? What are the ancestral practices? And so often it comes back to community. So we heal in community. This is something we've always done. There's always been a way that community came together and solved each other's problems. And sometimes that was really physically. So we would chant or sing together. We would dance in a circle together. We would develop rituals and ceremonies for different times of our life. And this is something that's of great interest to me. And I'm still exploring it both professionally and personally in terms of how it could look. But I think storytelling is how we have always healed, how we've always helped people through these stages of life. Every single cultural lineage, if you look back through ancient tomes, if they're available, storytelling has been a part of our history. And I think it's unfortunate that we're not giving it the credit of being medicine that it always has been. So I always encourage people, whether they're facing a new life or disability or any of those stages of life, to consider what the story is. And one of the things I always say to my patients is, that's one story that's available to you. And I always wonder if there's another story that is possible. Because the story that we tell ourselves about meaning and connection has flexibility. And the opposite of trauma is not being locked into a single story. It's that flexibility of having multiple pathways available to you. And so there isn't always one story available. There's always multiple stories. And I always encourage people to explore that. Not just the power of storytelling, but the power of different stories, I think is really meaningful and protective.
I love that. And I wonder if one of the ways that we could be applying your modern trauma toolkit in MAiD is to ask that question about storying. If this is the end of your physical story here on Earth, what do you want that to look like? How can I be present with you and be part of that? What do you need from me and what do you need from those people around you? As I begin to think about the characters for that story, I'm a big advocate for the idea of thinking about MAiD care. And I see your work in the book that you have written as being an essential piece to that, to help us to think about our roles, our responsibilities, so that we can be in community. Thank you for being part of our community, Chirstine. Thank you so much for creating community on TikTok, through the book, the TEDx talk, and for coming to speak with us here on Disrupting Death.
It was a real pleasure, Kathy. I enjoyed it. You brought up some linkages that I haven't thought about recently, so it was really wonderful. Thanks.
Yet again, Carrie Lynn, I thoroughly enjoyed our conversation with Dr. Gibson.
Absolutely. I feel like I would like to have her back again and again so we could really flesh out so many of the things we got to talk about today.
And I have to say, I felt throughout our conversation, I am so glad there are people like her out there providing MAiD to people for whom it's appropriate.
And to hear that not only has she been providing MAiD since the year dot, but that she was the only one in a city hospital is just remarkable to me. That really floored me when I heard that.
Yeah, that was a bit of a jaw dropper as well. I often think here, maybe in rural Northern Ontario, you might be the only doc providing it for your community. But to be the only physician in a large hospital in a large city, that's a little tricky to get your head around. And then to be able to pay such close attention to the work and the care that you're providing and put it in an accessible format that is her book, The Modern Trauma Toolkit. And the way she talks about that and how we can learn and think about that as we move forward to disrupt some of the trauma, particularly around end of life.
Exactly. And that talk about accessing the vagus nerve and changing even the tonality of her speaking voice. We talk about palliative care, and to palliate literally means to cloak. Reading Christine's book, I felt like she not only was holding my hand, but really had enveloped me in this sense that she was going to take care of me and ask that I take care of myself while I delved into the depths, as you said, about what trauma means for me and what I've done with the trauma that I've experienced and continue to navigate. Incredible. So pleased she reached out to us.
Me too. Me too. And so, dear listener, if you know of someone we should have a conversation with, if you know someone who talks about medical assistance in dying in a way that we haven't addressed at this point in the podcast, we would love to hear from you, from them, because I think it's really essential now more than ever that we work hard to keep our conversation going. So thanks for listening. Great to connect with you, Carrie. Let's keep the conversations going.
When did we get here, and how? Your stories mean everything now. When did we get here, and how? Your stories mean everything now. When did we get here, and how? Your stories mean everything now. When did